Good morning, everyone, and welcome to Jaipur Surgical Tutorial. Today, we have a presentation by Dr. Jasmeet from SDMH. He's going to talk to us about perioperative therapy in rectal cancer. And to moderate this session, I have invited two special experts. Dr. Lalit Mohan Sharma, he is a senior consultant in medical oncology at our institution, Mahatma Gandhi Medical College and Hospital. And Dr. Anushree Loyal, she is a associate professor of radiation oncology. I have some institutional commitments, so I will be leaving in between. Dr. Lalit and Dr. Anushree will continue to moderate, and Dr. Nagar will coordinate. Jasmeet, you can start. Do you want to say something?
No, sir. So, Dr. Jasmeet, please start.
Okay. Very good morning, sir. My presentation for today will be on the perioperative therapy in rectal cancer. So, I'll be covering my topic under 4 headings. First one would be what is the standard therapy which we have been giving so far. The next would be the upcoming thing of a total neoadjuvant therapy. And then there is a very off-late recent trial of under the heading of a prospect trial. And in the last, I'll discuss few slides on the watchful waiting on the organ preservation, which is very upcoming thing. So what is the indication to give any perioperative therapy in a carcinoma rectum patient? The definitive indications have been, so far, has been a T3 or a T4 rectal adenocarcinoma. Although T3 is still under doubt and there is a few controversies, we'll discuss that later. And any node-positive tumors, a tumor that threatens the mesorectal fascia, and even some studies would suggest in every mucinous subtype we should give a neoadjuvant therapy. And also EMVI positivity are the few indications of any perioperative therapy. This is just the staging. In a T1, T2 tumor, there is no controversy. It is clear that we can go for an upfront surgery. The surgery has to be a local excision or an anterior resection. That is a point of debate. But this is the category T3, T4 tumors or nodal positive tumors are the one which definitely require some sort of a neoadjuvant or a perioperative therapy. From many years, we have been giving this short course radiotherapy, which has been historically given in some very early small T3 tumors. It is given as a 25-gray radiation in 5 daily fractions over a week, with the advantage of operating the patient on the 7th day. So there have been 3 trials which have compared the role of radiotherapy with a surgery alone. These have been the Swedish rectal trial, the Dutch trial, and the MRC trial. I'll briefly discuss the top 2 trials. So in the Swedish rectal trial, we divided the resectable CA rectum patients into 2 groups. One group went for upfront surgery, whereas the other group underwent a radiotherapy followed by surgery. So in the results, what is there to be seen is that local recurrence rate was around 11% in the radiotherapy group, whereas in the surgery alone group, it went up to 27%. Although the overall survival has largely been comparable in the 2 groups, which is on the expected lines only. And if we go to the next trial, in the Dutch rectal trial, again we divided into the similar pattern, and the group of patients who received the radiotherapy, the local recurrence came down to as low as 2.4%. What is the difference between the 2 trials? In the Dutch trial, we have standardized the surgery in the form of a TME alone, whereas in the Swedish trial, the surgery was not standardized. So it is important to know that when we give a preoperative radiotherapy with a standardization of surgery, the local recurrence rates can be brought down to as low as 2.4%. Now, this is the next conventional radiotherapy, which is the long course chemoradiotherapy. It is given in the form of 45 to 54 gray in 25 fractions, which is given along with the concomitant chemotherapy, which mainly acts as a radiosensitizer, which is ideally either a 5-fluorouracil or its derivative of oral capacitor B, which is then followed by a surgery 6 to 8 weeks later. Since many years, any sort of therapy which has been given has been in the adjuvant setting. It was only after the introduction of a German trial that we started giving therapy in the neoadjuvant setting. So what was the German trial? German trial divided all resectable tumors into 2 categories. The one who received the preoperative neoadjuvant therapy versus the second group which received a adjuvant chemoradiotherapy. So what was given in the results? It was only the local recurrence which was lower in the group which received a neoadjuvant therapy. And they even followed up their data after 14 years, and that also showed a very low recurrence rate even after 14 years in the neoadjuvant group. How was this achieved? So what is believed is when we give any therapy in the neoadjuvant setting, there has been a better compliance rather than what has been given in the adjuvant setting. So that would give us into a better local control. It is also believed that the tumor oxygenation is better in the preoperative treatment rather than the postoperative treatment. So radiation seems to be a better modality when given in the neoadjuvant setting. Also, giving something in the neoadjuvant would give us an option for better sphincter preservation in the future. So it was this trial which was pivotal in establishing the role of preoperative chemoradiotherapy as the standard of care, which has been followed since then, even now. So whether to add anything in the preoperative radiotherapy regime was evaluated by EORTC 22921, which was the largest trial. It concluded that when we added some sort of chemotherapy to the neoadjuvant radiotherapy regime, there is a higher rate of pathological complete response with fewer cases of LP, lymphovascular invasion and perineural invasions. But there was no improvement in the overall survival at 10 years, which was a bit astonishing, as it is expected addition of any chemotherapy should give us some better overall survival over the years. But then it has been discussed that the dose of chemotherapy that we add to the radiotherapy regime is very minimal, and the main role of those chemotherapies is to act as a radiosensitizer. Now, when to operate upon the patient is the biggest controversy. There have been many. It is believed that after any neoadjuvant therapy, if we wait longer, we tend to get a better complete response. But with the longer wait after radiotherapy, the risk of surgery definitely increases. The complications associated with surgery on the radiation-induced toxicity, they tend to increase with the time. So there is a controversy whether to operate early or to operate late. So there have been many meta-analyses which concluded that waiting for more than 8 weeks after the neoadjuvant therapy tend to increase the pathological complete response rate by 6%, while more or less the complication rates tend to remain similar. So there have been 2 randomized trials which have compared the timing of surgery. One was the Lion R90 trial. It compared at less than 2 weeks versus 6 to 8 weeks intervals. So this told there in the latest update, they have told that longer interval of waiting was associated with higher number of PAC-CR rates, but it was not associated with any overall survival rates. Similarly, another trial was a Greca trial. It compared the surgery intervals at 7 weeks versus 11 weeks. It tells that waiting for 11 weeks had no significant increase in the PCR or sphincter preservation rates. But as expected, if we waited longer, there were higher rates of difficulty in surgery by conversion to open. And also, it has higher post-operative morbidity with the larger waiting rates. So, based on these, there is a consensus on timing of surgery, which is again discordant between various societies. The ESMO society clearly states to wait for 6 to 8 weeks after completion of any neoadjuvant therapy, whereas NCCN guidelines suggest that surgery should be performed 5 to 12 weeks following full dose of neoadjuvant CTR. Now, there was another concept that after giving a short course radiotherapy, can we go in for a delayed surgery? The main downside was whether we would be compromising on the oncological outcome. So that was assessed by a Stockholm 3 trial. It said that if we delayed surgery after short course radiotherapy for nearly up to 8 weeks, it would give us similar oncological results as compared to a short course radiotherapy with an immediate surgery. This was a 4-arm trial basically, but I'm just telling the results. So although the radiation-induced toxicity as expected, it increases with the delay, but based on this trial, we can conclude that short course radiotherapy with delay to surgery is a very useful alternative which can be used without compromising any oncological outcomes. Now, there have been 2 trials which have compared the short course radiotherapy with the conventional long course radiotherapy. None of the trial could conclusively tell the advantage of one over the other. So, based on these findings, it is practiced in every institute, whatever they feel comfortable with. They are largely the same results. There is no superiority of one regime over the other regime. Now coming to total neoadjuvant therapy for rectal cancer. I will cover in these headings. So what is the standard therapy that we have been giving so far? It is the first chemoradiotherapy, which is 45 to 54 gray, followed by any radiosensitizer, followed by a surgery, and then adjuvant chemo, which is again doubtful. Now, what would TNT means? Total neoadjuvant therapy means using of any sort of radiotherapy or chemotherapy prior to undergoing any radical surgery. The radiotherapy could either be a short course regime or a long course regime. Now, the sequencing is of two types. It is either an induction or a consolidation, and it is based on the chemotherapy. If the chemotherapy is given before radiotherapy, it is called as induction regime. If the chemotherapy is given after radiotherapy, it is called as consolidation regime. Why? What would be the actual need of giving a TNT? Distant recurrences has always been the major cause of morbidity in the patient who underwent a rectal cancer surgery. So, to prevent or early tackle the micrometastasis, it was postulated that if we give a chemotherapy in the early part, that might help us get a better overall survival or metastasis-free survival. So, also it has been seen by giving TNT, we tend to achieve a better pathological complete response that would facilitate in a better R0 resection as
sputum,
So also with the adjuvant regime, there has always been a problem of compliance. Not everybody is able to take a full course of chemotherapy after surgery. It is postulated giving a TNT would improve the tolerance and help into completion of chemotherapy. This was also validated by EORTC trial that 73% of the patients who started adjuvant chemo, only 50% of them could finally complete their regime. Also, it has been shown that there is no major advantage of overall survival by using only adjuvant chemo. So it is thought to try that chemotherapy in the neoadjuvant setting. Now, what is the evidence for TNT? Of late, there have been three major trials in the name of Rapido trial, Prodigy trial, and Oprah trial. We'll go to each of them one by one. So, what is a Rapido trial? In the Rapido trial, they compared the standard treatment arm with the experimental arm of a TNT therapy, where the radiotherapy used was a short course radiotherapy, followed by 9 cycles of FOLFOX or 6 cycles of KPOX, followed by surgery. The primary endpoint for them was a disease-related treatment failure. So we see at the end of 3 years, the TNT arm had a lower rate of treatment failure in the form of 23% as compared to a 30% in the standard arm. Other relevant results, even the distant METs at 3 years, they have come down a little, but it has not shown statistical significance, although overall survival at 3 years is still same in the both arms. But the major thing that turned out after giving TNT was that PCR rates, they were remarkably better in the TNT arm in the form of 28.3 versus 14.3%, which would later extrapolate into organ preservation if the patient wished to. The rest of the complications are same between the two groups. The next was the Prodigy trial. In this, they again compared the standard arm with the experimental arm, whereas in this, the regime given was not a short course radiotherapy, but it was a long course radiotherapy. So the median follow-up was 46 months, and there again primary endpoints for disease-free survival, METs-free survival, and overall survival. And all of them showed a slight better towards the TNT arm. Even again, the PCR rates are also significantly better in the TNT arm. This third one was a basically organ preservation trial. It was a trial that compared the two arms of TNT therapy, induction versus consolidation. So both of the arms were compared, and again, the results were largely same whether we use an induction arm or a consolidation arm, with slight better organ preservation rates expected with the consolidation. Now, what would be the pros and cons? The benefit of TNT would be there is expectedly a better compliance as compared to a standard arm. Theoretically, we believe it decreases distant METs. There is a better prospect of organ preservation. And as it is with any neoadjuvant therapy, it gives us the option to study the tumor and its response to treatment. And we might not tend to operate on the patients who have a progressive disease and tend to keep them out early from the treatment. And what would be the downsides of using a total neoadjuvant therapy? There is a risk of disease progression, which we might not realize. Also, there might be some treatment toxicity with the early chemotherapy. What are the challenges? Although the evidence for TNT is very early, but it is coming up, it is still not accepted by many centers. There is a concerns about surgical numbers. If we give all the therapy, the neoadjuvant patient might not end up to surgical table because of a longer treatment that has gone through his time. And there is also, as expected, concerns about disease progressions. And still, which is the optical sequence? Whether it is induction or consolidation, although it has not been defined, but OPRA currently suggests consolidation to be better than induction. So this is as we all know, the current guidelines for adjuvant treatment after completion of neoadjuvant chemoradiotherapy are not well formalized. This is given by ESMO. ESMO clearly states that in the stage 1, there is no need of giving any adjuvant therapy. In stage 2 patients, we have to discuss with the patient about the lack of robust data, and if the patient agrees to receive adjuvant chemotherapy, a single agent regime can be given to stage 2 patients. Whereas in stage 3 patient, we need to discuss it with the patient and we should advise a doublet regime of a oxaliplatin-based chemotherapy. Just a broad outline from where we have started and where we have landed in the treatment of CA rectum. Initially, in the early 1985 era, we only used to give everything as an adjuvant therapy. It was a total chemoradiotherapy given in the adjuvant setting. Then, with the advent of German trial, we moved up to a neoadjuvant setting. And then slowly, as of today, with the advent of total neoadjuvant therapy, the only treatment which is given is in the neoadjuvant setting. And that is the transition in the treatment phase of rectum. Just to summarize what we have done, is the perioperative treatment still necessary if high quality TNV surgery is performed? Answer is yes. It might not improve survival, but giving a radiotherapy before surgery, it tends to reduce the risk of local recurrence. Should radiotherapy be delivered before or after surgery? As confirmed by German rectal trial, it has to be given before the surgery. What is the standard preoperative treatment regime? This is the current standard of care, which is the long course fluoropyrimidine-based chemoradiotherapy or a short course radiotherapy followed by surgery, and both are equal in their results. What is the best timing? Our take-home message for us would be anytime between 6 to 8 weeks after preoperative treatment, the patient should undergo a surgery. Now, is there any role of adjuvant chemotherapy? As we have discussed, the role following preoperative treatment is uncertain, and pros and cons has to be regularly discussed with the patient to achieve a final therapy. Now, what is the rationale of giving a preoperative chemotherapy as in TNT? The rationale is that, as I've discussed, the distant recurrences are the one which represents the main cause of treatment failure, and they should be addressed early by delivery of systemic chemotherapy. And what is the new standard of care which is upcoming? That is the total neoadjuvant therapy, as we have discussed. Now, this is the next part of my talk, which is the role of prospect trial. So, is radiotherapy an essential component of the preoperative therapy? Can we really omit it? There was initial work done by a few Chinese centers under the heading of a FOVAC trial, which has been later carried on by this prospect trial. What is the outline? This trial propagated that most locally advanced rectal tumors, they can receive a curative treatment without pelvic radiation. Now, this is very important. Which patients they selected? They only selected the patient who were subgrouped into an intermediate risk. They clearly excluded all high-risk patients. And what is the exact intermediate group? I will discuss at the end. So, if this is true, is it a big deal for us? Yes, it is a big deal that we have been radiating such patients from the last 30 years. And if they could be omitted, the major complication of our treatment have been a pelvic radiation. And are we doing that unnecessary? Oh, this was the trial design. They divided the patients into two groups. The first group received a standard pelvic chemoradiation regime, followed by surgery, followed by adjuvant chemo. In the second group, which was the interventional arm, they gave 6 cycles of Follow-Hox. They restaged the patient. If the response was more than 20%, the patient underwent surgery without any radiotherapy. So what are their results? The disease-free survival at 5 years between the two groups has largely come out to be same. That is understandable, but the freedom from local recurrence without giving radiotherapy is also same between the two groups, which was a bit surprising. The overall survival at the end of 5 years is also comparable between the two groups. So based on these trials, they have extended the therapeutic option by showing the non-inferiority of neoadjuvant FOLFOX with selectively using chemoradiotherapy in non-responders as a prevailing standard for standard neoadjuvant therapy. Now, can this radiotherapy be omitted as of now? While the results from preliminary study are promising, the confirmatory data is needed before routinely omitting preoperative radiotherapy, mainly for high-risk tumors. All the trials, they only take the intermediate risk tumors. Now, this is the last part, is there any role of organ sparing management strategies? Now, after giving a neoadjuvant therapy, how do we assess the complete clinical response? It is done on 3 aspects only. We have to do a DRE, we have to do a scopy, and we have to do a MRI. When all of these say complete clinical response, it predicts a 98% correct complete clinical response. Now, what are the major risks of putting a patient into watchful waiting regime? If this patient, if he develops any sort of recurrence, whether that be a local recurrence, and if that is a local recurrence, and will that be amenable to a salvage surgery? Or whether the recurrences they develop into a distant metastasis. This is the major bone of contention. There has been a watch and wait database. They have reported that nearly 25% of the patients who were in the watchful waiting, in their follow-up periods, did develop some sort of recurrences. And this was the original paper by Haber Gamma, which told that over the 3 years period, most of the recurrences were documented, and beyond 3 years, there were very less patients who eventually recurred. And all the recurrences that happened, 90% of them, they had some sort of endoluminal component. So this is contrary to what we see in the esophagus Sano regime. When the patients who are put in the wait and ward regime in the esophagus, the recurrences they develop, they are largely metastatic recurrences, whereas recurrence which happens after a watchful waiting in the rectum, they are mostly endoluminal recurrence. So this is the data of all the patients who have took part in the watchful regime, and they have told that salvage surgery is possible in nearly 100% of patients, except for this Datani meta-analysis, which has depicted in 88.4% of patients. And in the next, we see distant metastasis in the next row. It is also very less, in the order of 4 to 5% in the major studies. And in the patient who have been on the watchful waiting, the survival data is around 86%. Over 10-year survival data, 80% or 86% in the various studies. So where does NCCN stand on watchful waiting? It clearly states that in those patients who have achieved a complete clinical response with no evidence of any residual disease, either on a DRE or MRI and a scopy, a watchful waiting non-operative management may be considered in the centers with experienced multidisciplinary teams. Just to summarize this watchful waiting, the most patients who develop a regrowth, they are salvageable. Careful patient selection with close monitoring is the key. High proportion of patients, they tend to achieve organ preservation, and the survival results so far given are quite good. This is my last slide. The ESMO guidelines published this in 2021, that how our treatment modalities for a locally advanced rectal cancer would look in the near future. And today, this is how it looks as of me. A low-risk disease is divided as a T3A/B tumor, which is in the upper rectum or in the mid-rectum. In such cases, if the surgeon feels confident, we can directly go ahead with the TAB without giving any neoadjuvant therapy. Now, this is the next group, the intermediate risk group, which has been described in all this prospect trial. This is a group of patients who have any T3 low tumor or a T3C or T3D high or mid-rectal tumor with a node positive disease, which is N1. It has to be EMVI and CRM negative. This is the intermediate risk group. In this group, we can have various modalities, which could be either a short course radiotherapy followed by surgery, or a long course chemoradiotherapy followed by surgery, or a total neoadjuvant therapy followed by surgery. And if this patients they achieve a complete response, we can put them into a local excision rates. Now, what is a high risk group? High risk group is a patient who eventually have a T4N2 disease, who have a lateral lymph node positivity, who shows EMVI positivity, the levator muscles are threatened, and the CRM is positive. These patients, there is no role of giving short course radiotherapy. The only treatment modality available in such patients would be to select a total neoadjuvant therapy or maybe a chemoradiotherapy followed by a surgery.
So thank you so much, Dr. Jasmeet. You have summarized the whole concept of neoadjuvant therapy, total neoadjuvant therapy very well. And I think we have covered most of the practical challenges. So any questions, comments from the audience? So if there are no questions, may I ask you that is the pathological complete response surrogate marker for the response of the neoadjuvant therapy? It was seen up to 30% of the patients. So you feel there are other ways by which we can further improve the pathological complete response?
We can detect by these methods only, sir, after doing a biopsy, and we can add a biopsy to look for a better PCR rates.
Yeah, in fact, currently, whatever methods are available, we are able to achieve up to 30% patient going for complete pathological response. And after seeing pathological response, many times we feel that whether surgery was also needed or we could keep these patients also in wait and watch.
Yes.
But again, like such things are to be practiced only in high burden institutes where all the wait and watch policies, multidisciplinary tumor boards are there, and the patient is also compliant. Other thing wanted to ask you that do you feel any difference in the Indian and the Western patients?
Definitely, sir, the patient are not that compliant. To put the Indian patient into a watchful waiting
Other
regime
than
is very.
compliance and the, do you feel difference in the biology?
The mucinous tumor rates are comparatively less in the Indian patient. The Western patients tend to have a
So
higher.
commonly in India, what we see is younger age is seen.
Younger.
Younger patients are coming more to us than the Western world. Second thing, signet-ring variety is also very common in India as compared to Western world. So both these are like high risk for the patient population. So again, the more of neoadjuvant therapy remains a goal for our patients so that the colostomy duration is reduced and more patients can go for the organ preservation. And other thing wanted to like very important point you highlighted and once again in the benefit of everyone that the radiation effect is seen after 8 to 10 weeks. So the short course RT and then do surgery within 1 week again is not a good idea. It is better that we allow the radiation effect to carry on. And there have been studies where induction chemotherapy followed by CTRT or CTRT followed by consolidation therapy, chemotherapy. So the results were better if the duration after radiation plus chemotherapy is longer. So the consolidation arm did better. Other thing you rightly mentioned and very important practical point that almost 30 to 50% of the patients after radiation and after surgery, they are not able to undergo the adjuvant chemotherapy. So we are not able to maintain the intensity. So whatever treatment is to be done, it is always good that we do it before taking the surgical aspect. And to me, it looks still the biggest revolution in the management of rectal cancer is the TME. Probably that has made significant impact in the overall outcome, and the quality of life remains much better. So my co-moderator is Dr. Anushree Poonia. I am giving to Dr. Anushree for her comments.
It was a very nice presentation, and you have covered almost all the points. So one is one downfall or pitfall of TNT is we may overtreat some patients. So whenever we are analyzing whatever data we have to see what patient population they have selected, because most of the trials except for Rapido had selected intermediate and high risk patients. Only the Rapido trial had selected high risk patients. So that is one what we need to check. The other is the site of tumor in the rectum, we have to see what, like if it is a low, mid, or upper rectum, that is also important when we are selecting our therapy. And regarding intensification and de-intensification, as you have already mentioned, Prodigy trial tried to intensify the treatment with the intensified chemotherapy, and Prospect trial tried to intensify the therapy. So, but we have to carefully select the patients in whom we can de-intensify the treatment and in whom we have to intensify the treatment. And which chemotherapy we have to select. There is one more ongoing trial, which is the Genus trial, which is comparing FOLFOX versus FOLFIRINOX. And most of the recent trials, they are incorporating long course radiotherapy as compared to short course radiotherapy. So that you have already mentioned.
Dr. Nagar for comments.
Thank you, Lalit Mohan sir. Thank you, Anushree, Dr. Anushree. And regarding, first of all, my surgical colleagues and my resident also, one more thing I want to add here is the short course radiotherapy and long course chemoradiotherapy. So the group of the patients in which we talk regarding which group we select for the short course radiotherapy is the Jasmeet, you have very well mentioned in the last slide. You have given that the short course therapy we can go in such cases like you have shown this, but this is the tabulated form I can say if the patient is having large bulky tumor in the rectum, no need to think of short course therapy. It's a long course therapy because we want to downstage the tumor, downgrade the tumor. Okay, it's more my surgical colleagues. Don't think why can we cannot give for short course radiotherapy. Okay, another is like you have told this Haber gamma. This is basically the important crux here. Not wait and watch. Important watch and wait. You have to examine the patient every time and then wait. That's why they have given the name in their study, watch and the wait. And the watch, there's an extensive surveillance protocol there. Probably every 3 months, as I know, every 3 months they call the patient for the investigations like distal rectal examination, MRI, and these extensive examination, colonoscopy or sigmoidoscopy they do. These things is not possible in our country. Now you can see our patients, many of the patients forgot to take a adjuvant therapy. Now these patients will probably will not come for this surveillance of these patients. Okay, so this Haber gamma probably will not be possible in our country, but whatever Dr. Liltman says regarding this.
So I think most of the things, and we are lucky at Mahatma Gandhi Hospital that we have excellent team of various super specialties, subspecialties, and we are having regular tumor board. And since most of the colleagues here are the surgical colleagues, so my again request will be that we try to do more and more of organ preservation, more and more of the reduced duration of the colostomy, so that we can do upfront chemotherapy, radiotherapy, everything. And again, to my radiation and chemotherapy colleagues, that we always counsel that there is no like surgery will be done, so that the patient and family is prepared. Sometimes the surgeon tells them, once we do surgery, then later on we'll see, based on report, we'll take the call for further treatment. So again, there is chance that such patient may lose, and we may lose. Sometimes after giving CT plus RT, if there is good clinical complete response, the patient may go default. Without observation, they may feel that my disease is gone. Why should I undergo surgery? So just with for understanding, there is difference between downstaging of the tumor and downsizing of the tumor. Dr. Kapoor is very fond of teaching all these things. So with the neoadjuvant chemotherapy, with neoadjuvant whatever technique we use, we are downsizing the tumor. The stage remains the baseline stage.
Right. Sir, I have one doubt. What is the current guidelines for giving a radiotherapy in upper rectal tumor? Are we regularly using it or we are selectively using it?
Dr. Anushree is expert in the radiation, so she will answer this question.
So T1, T2, N0, we know there is no role of neoadjuvant treatment. T3, N0 is a gray area. In lower rectal tumors, we some still prefer, but in upper rectal tumors, it is not required, and we can go for upfront surgery. And anything beyond that, neoadjuvant treatment has to be given.
Even in upper rectum, we are using radiotherapy. No?
Not for T3N0.
No, in the high
Beyond
risk.
that,
Beyond that.
high risk. Yes. Yes. Yes.
So Jasmeet, just for the benefit, can you show us the prospect trial flowchart again? There is some important point in that. Yes, here only. So if you see here very clearly, they have divided the patient in the lower after the fall fox. Restaging is very important, and again the restaging, the MRI quality is of utmost importance. The MRI which many times we get is not of that quality. And second thing, the radiologist reporting the MRI should also be well experienced about reporting the response. Otherwise, we may like lose, if it is a routine MRI reporting, we may lose the exact reporting method. And very clearly mentioned about the role of surgery and avoidance of pelvic chemoradiation in patients who are showing very good response. And even they tried that patients who had shown suboptimal response. One is gross residual disease, other was intermediate,
Yes.
where the surgeon was plus minus, and one was absolutely like complete response. So in patients who had suboptimal response, even with the prolonged watch and wait policy, many patients have shown complete response also. And the good point you highlighted is that most of these patients, even if they have recurrence, the recurrence is 90% of time, it is within 2 to 3 years, and they are in the pelvic region where surgery is. I think these all are very good learning points you have highlighted. So, Dr. Nagar, anything?
Regarding the investigation of these patients, is the MRI. So, though the concept of the MRI, which was introduced in this rectum, is through the Mercury trial. Mercury trial shows that the MRI should be reported on the specific points, how it should be done, which area should be taken in this the pelvic MRI, and how it is reported. So, every resident should read the Mercury trial in which they have given the how to report, how to read this pelvic MRI for every resident. And if we have a no question, you want to comment? Any comment from the resident or anyone want to ask any question? If no question, then we can close the session.
Okay, thank you, Dr. Jasmeet, and thank you all the
Thank you.
participants.
Thank you, sir. Thank you.
Okay, then we wind up for today. Thank you so much and have a good day. God bless you all.